Okay, I'm going to take myself off video because I realize you don't really care to see me. You need to see the slides. Okay. Everybody should be able to see the slides now. We'll get started. Uh, I'm Sam Lim, and it's a pleasure to be with you all tonight. Today's December the 6th, and this is our virtual town hall about COVID-19 in our community, sponsored by the Lupus Foundation of America, Georgia chapter. We thank Terry Emond, as always, for doing so much behind the scenes and supporting us. I also represent the Goal Project at Emory University, where we're doing a lot of research on the impact of lupus as well as COVID directly in our community. And also want to thank the Georgia Council for Lupus Education and Awareness. So just please take a look at this disclaimer, and it's also on the website. Okay, so this is how we always start, and the numbers get really blurry and fuzzy and big and really hard to relate to sometimes, but they're worth always repeating and thinking about. We have over 65 million confirmed cases and over 1.5 million deaths worldwide. The US has the highest number with greater than 14.5 million cases and 282,000 deaths. India and Brazil are numbers 2 and 3. Russia and France have more than 2 million cases. And the following countries have more than 1 million cases: Spain, the United Kingdom, Italy, Argentina, Colombia. And then off this graphic, we also have Mexico, Germany, Poland, and Iran. Here we have a heat map of the current rate of new cases throughout the world. And because of this concept that you might have heard of from Dr. Fauci, a surge upon a surge, in a lot of cases, we actually had to come up with an extra category. Previously, it was enough to have just a red, but here, US as an example, is this very dark magenta color, which is really the highest grouping. And we've had to do that because of this extraordinary phase that we're in the US as well as in other parts of the world. But you see us as well as Canada having a decent number of cases, still a lot of countries in South America. You see Europe, although they're starting to come down because of the strict measures that are taking place in many of the countries that we've talked about in the past, but they're still in having to deal with a lot of cases, and it's going all the way over to the east and Russia and in Kazakhstan, Iran, as I mentioned earlier. But again, Asia is doing relatively very well, as along with Australia and most of the African continent. So again, including that extra dark magenta color, you can see where the hotspots are in the US, and it continues to focus mostly in the middle parts of the country, the upper Midwest, stemming from North and South Dakota and throughout that region. But there are plenty of other cases throughout the country, and the entire continental US, including Alaska, is very hot. The two states that have more than 1 million cases are California and Texas. And I'll talk about a little bit more about this in a minute. Georgia is relatively better off than many states, but one thing to keep us humble is that Georgia is number 5 in terms of total number of cases. So if you look at the totality of where we are, we're still in the top 5 with a little under 356,000 cases and nearly 8,000 deaths. in Georgia. But clearly the focus of the pandemic, at least in this surge upon a surge phase, has been in the Midwest and in other parts of the country. So as I discussed up the top here, this is how the number of new cases reported throughout the country has been. You can see the initial phase of the pandemic, and then you have the some people call it the continuing of the initial phase, but the second spike, if you will. And just to put everything into perspective, we're in this tremendous, extraordinary phase where the numbers are in territory that we're not used to, even when we think about the first two spikes. And it's led to the numbers that we're seeing now, and the percentage increase continues to go higher and higher. It seems like every week. And the concern obviously is continuing into the holidays, that these numbers really lag a couple weeks. So we haven't even felt the full effect of Thanksgiving yet. And we have not hit Christmas and New Year holiday periods either. In terms of deaths, we talked about how deaths always will lag behind the new cases. So deaths inevitably follow, but we're already seeing on a national level the increase in the number of deaths associated with the current spike in the cases. And all of that is no surprise in terms of looking at the number of hospitalizations. And as you're seeing and reading on in the news, that there are some parts of the country that are very close to or at the breaking point in terms of hospital capacity, particularly in the intensive care units where the sickest patients are. Again, these numbers and graphs can be a bit numbing, and I can completely understand that. One thing to put all of this into perspective is if you look at the past 3 months prior to November, we have a total of 4.46 million cases, which is nearly the number of cases that we had just in the past month in November. So we are in trajectory and in an upswing. Again, it's so hard to undersell. It's just really, really high numbers. So looking at Georgia, as I mentioned earlier, for those of us that live in Georgia, especially the metropolitan Atlanta area, I think we're certainly not immune to everything, as we said, and we have a lot of cases here in Georgia and in Atlanta. But relative what you hear and see in the national news, you get a sense that it's not as bad. And it sort of plays out in this graph here, or this picture, compared to the rest of the country where it's very dark magenta. We have only a few areas that are that hot, although most of the state is glowing. Some areas more red than others, but it's not the dark, deep color that you see in broad swaths of the rest of the country, which is something to be thankful about. And just to underscore that even further, this is from the White House Corona Task Force latest report. And this is looking at the last week or so in November, because their data lags about a week or two behind. They need some time to look at that. And I'm sorry that you can't really see the details, perhaps not so well, but this is looking at the national ranking of all the states with regards to the rate of new cases per 100,000 in the population. And Georgia is number 48. So it's just outside the lowest tier of the yellow, but we're the first group going into this second tier. And obviously we have a lot of other fellow Americans that live in states that are doing a lot worse in terms of number of new cases compared to where Georgia is lately. This is again from the White House Corona Task Force report, looking at the last week in November and looking at the number of new deaths per 100,000. And here Georgia continues to do relatively well compared to the rest of the country, being number 44. So as I mentioned, that all is a reflection of the shifting patterns of the pandemic, if you will. Looking back at 4 months ago, which is in the bottom right here, you remember us talking about how the concentration of the pandemic were in certain parts outside of the Southeast, but the region that had the most density, if you will, of cases was the Southeast. And then if you look across here, going into 3 months ago, and then up here in the upper right, 2 months ago, and then now about a month before, you see the shift of the pandemic going from the Southeast up into the Mississippi Valley into the upper Midwest. And then from the Midwest, it's really taken a foothold to have large numbers of cases throughout the middle parts of the country. In the middle parts of the country up here, these are not major population density areas. These are more rural areas. And that's what we're seeing, not just in the maps, but also in the numbers. So if you look at, these are COVID rates over time here on the bottom. So going from left to right, January up through October. And then you can see the initial pandemic here in February, March, and April. And this is broken down by rates in metropolitan versus small metro and rural areas. The large metropolitan areas in the dark solid line here. And for obvious reasons, people being so close together, these large areas really drove the initial numbers of the pandemic. But then, this current phase where the numbers are going up, we certainly have many cases in large metropolitan areas, and you've heard of New York and LA and Chicago, among others. You see these other dots and lines, and these represent much smaller cities. And that's what's really happening, is that the pandemic is being fueled mostly, but not exclusively, obviously, but predominantly in the rural areas relative to the urban areas. And so, we're seeing somewhat of that pattern here in Georgia as well. And this was what it was like early in the pandemic for Georgia. But just looking back in the past few months here in Georgia, you can see that going from October on the far left to December on the far right, that really the cases are concentrated in the outlying areas of the state, of outlying compared to Atlanta, that is, into the more rural parts of the state. So this is Georgia in terms of number of new cases. But again, to put things into perspective, even though our current spike, if you will, is not as high as the other parts of the country, we're still at a point where we've never been before as a state. We have more numbers of new cases per day than we've ever had in the pandemic. So, these still should be warning signs for us. And we always have to remember, again, the lessons of the previous waves, in that we're never safe completely forever, and that these things tend to come back. And the last thing you want to do is let down your guard. The number of deaths in Georgia, you can see, are starting to rise here up at the end, and they undoubtedly will continue to rise as the number of new cases go up in our state as well. Testing has gone up overall, but remains kind of flat, but better than the early parts of the pandemic, and the hospitalization rate is starting to go up. So the left figure is what I just showed you, that throughout the state, the hospitalization rate is going up. On the right is the metropolitan Atlanta hospitalization curves. The top line here is the total number of COVID positive patients in the hospital. Um, this includes both the ICU as well as the general floors, if you will. And you can see that the numbers are going up, and the trajectory is not very optimistic. It's not as high in terms of the total peak numbers as where we were before, but as I mentioned, we're not even seeing the full effects of Thanksgiving, and nor have we hit Christmas and New Year's and other winter holidays. So many people are betting that this will continue to go up and perhaps even exceed previous levels, which is something that definitely we need to watch, especially in light of the ICU, which is the bottom figure here, where the current numbers are much closer to the highest numbers before in terms of ICU ICU impact. And that's something that really makes us worried as we get closer to maximizing the most critical beds. So again, this is one way to look at the state of certain states and regions. If you go to COVID Act Now website, they have a dashboard, and they previously had only 4 colors, but like the previous maps that I showed you, we've had to go into 5, and with the dark magenta being the highest level and then red being right under that. We were previously at the peak over here in the red zone. Now we're still in that color red, but we have one more category that's ahead of us. But we're heading that way, and we need to be careful. It's really driven by the increased number of new cases that we're seeing in the state. And you can see that the ICU headroom, which is kind of a sense of the capacity of the intensive care unit patients, it's getting much higher than before. Now, I did mention that metropolitan Atlanta has been relatively less hot than other parts of the state, but it's still relatively going up. And if you look from 2 weeks ago or so, in Fulton County, you see the daily number of new cases from 18.7 to 29.4. So the rates are definitely going up in all areas. And to further underscore this, we have DeKalb County, which has not gone up as much, but it's going up. So it went from 20.2 to 26.5. So other news since our last town hall, some of you have heard that President-elect Biden urges Americans to wear masks during the first 100 days of his presidency, and will use his authority to require masks in federal buildings and on interstate transportation. And we'll touch a little bit on the ongoing use of masks, even through the period of vaccination, in a little bit. Dr. Scott Atlas, who is a very controversial figure as an advisor to President Trump for the nation's response to COVID, has resigned from his role. CDC changed their quarantine guidelines from if you were known to be exposed or to somebody who tested positive or highly suspicious for having COVID, you went from being advised to quarantine from 14 days to either 7 days if you had a negative test yourself, or 10 days without a test. The Strategic National Stockpile, which stockpiles very critical supplies of oil and other critical supplies for the nation's strategic efforts, included supplies for the pandemic, but it's facing critical shortages in the gloves, masks, gowns, and goggles. The FDA granted emergency use authorization for a treatment for for COVID to Regeneron's experimental antibody treatment, so it just floods the body with antibodies. The WHO does not recommend remdesivir to treat hospitalized patients based on some of their data. And as I touched on, we're going to switch to talking a bit about the vaccines. We've talked about them a bit before, and we will continue to talk about them in even more detail. But this is such a timely thing to discuss, obviously, for many reasons. But one of the things to point out is this past month in November has been a tremendous month. It's someone quoted as the magical month for vaccines, because every Monday, except for the first Monday in November, we started out the week of having a huge press release about a new vaccine. And so there's been a tremendous activity in the past several weeks. And I'll do my best to at least give you my perspective of the background of what we're seeing so far. And this is a bit in line with some questions that were submitted for tonight. What's the difference between these vaccines? And are there going to be any long-term studies of these effects of these vaccines, or the safety, especially long-term? So I pulled some slides from a nice talk that I heard from Dr. Colleen Kelly, who's an infectious disease expert at Emory, that I will share with you today. Because they, I think, kind of put things into context very well. Not that, I can, or anyone really can answer all of these details in terms of the questions that you may have or were posed in that previous slide. But this will be, I think, at least a nice summary for everybody to be level set, to kind of understand where we are now. The first news that really came out in November was the Pfizer vaccine. And the Pfizer vaccine is an mRNA vaccine, and some of you may or may not. Some people know what mRNA vaccines are, and the details of that, or others may be quite interested in that. We may go into some of the details. I touched a bit upon what mRNA vaccines do last week, so you can go back and look at, 2 weeks ago, and you can look at that video. And we may go into some more detail. We probably will in the coming weeks, but I don't want to get too lost in the weeds. But I will point out that, for those of you who have heard of the term mRNA vaccine, it's a new sort of technique that's used to develop the vaccine, and this is the first one of them that came out. It enrolled over 43,000 people, and it showed tremendous results, 95% efficacy across all groups. And just to give you an idea of what's behind this, what does 95% efficacy mean? Well, it means in the group that did not get the actual vaccine, there were 162 cases of confirmed COVID, and only 8 in the vaccine group. And that difference is huge. And it really is behind this incredible number, which is much greater than anybody really anticipated. I think, my sense from reading and talking to the ID folks is that we would have been, very happy with something with an efficacy rate around 70%, maybe even 80%. But to have numbers in the mid 90s is just tremendous and exciting. Pfizer anticipates having 50 million doses available by the end of this year, with a total of 1.3 billion additional doses in next year. The thing to know about the mRNA vaccines is that, and I think we'll touch upon this in a little bit, is that it's a very delicate vaccine. And in order to stabilize it, the best way to do it is to freeze it. And it needs to be kept frozen in very, very cold environments. So -70 is way below what a standard freezer can do, and really only present up until recently in research labs. I have two myself to store some samples that we have to keep things like mRNA that we study for lupus stable, but hardly ever used before. Now there's a tremendous need, obviously, for these freezers that are not easy to find. You can't just go to Walmart and buy one, um, and we need to keep them at very cold temperatures as long as possible. The emergency use authorization was requested and submitted to the FDA on November 27th, and there were 2 months of safety data behind that. The FDA meets in just a few days, and the first vaccine may be given within 24 hours after what we anticipate will be an approval. The UK had their paperwork done much quicker, and they have already an approval, but the first vaccine has not yet been given to an actual person just as yet, but it's imminent any second or day now. Moderna is the second of the mRNA vaccines. This is a company out of Boston and Grady, by the way, / Emory, but most of the cases, patients were from Grady, participated in this study of this vaccine. And they announced a week later in their study that enrolled over 30,000 people that their vaccine was 94% effective across all groups, showing a tremendous difference again between people who did not get the vaccine and those who did, and protecting against COVID. They will have 20 million doses by the end of this month and 1 billion doses in 2021. This also needs to be stored in a relatively cold environment, not as cold as the Pfizer vaccine, but cold enough. And the emergency use authorization was submitted on November 30th with 2 months of safety data, and the FDA is scheduled to evaluate this just about a week or so after the Pfizer. So the last Monday before Thanksgiving in November, there was the news of an AstraZeneca vaccine, and this is not an mRNA vaccine; it's a different modality. And there was some confusion that behind some of the results, which still persists. It initially they announced that the average efficacy was 70%, but surprisingly, there was a group that received half the dose, and it was actually by mistake. And I don't really quite understand fully how that happened or why, but nevertheless, this group had an even larger efficacy, so 90% in that group. And these were people in the United Kingdom and who were less than 55 years old. And then when they looked at the full dose group, the efficacy was much less. The people were mostly from a different part of the world in Brazil. And there were questions about whether there was delays in these people getting the second dose, or where there was differences in manufacturing. And but the thing behind all of this is that there was efficacy. It's somewhere like around 60 to 90%. And the good news also is that it was a relatively well tolerated vaccine, but there were really more questions than answers. And it's to the point where the company actually may conduct a whole new trial just so that they have all the answers and people feel at ease with the results. Now, you may look at all of this and say, why even think about this vaccine compared to what I just mentioned, the other two from Pfizer and Moderna. But we have to, and we will continue to need other vaccines in the mix. There's tons of people, billions of people that around the world that need to get access to vaccines, and we need different ways to do it with different manufacturing lines, different processes, um, and we may learn that some are, depending on how the vaccine was created, some may be better in other groups. And also to the point of supply chain, this is a relatively cheaper vaccine compared to the first two, and it does not require ultra cold storage, which obviously would be a big advantage throughout the world, but especially in the areas that are particularly resource poor. Now, when we talk about safety with vaccines, we're all very excited about seeing the efficacy that these are effective in protecting people from getting severe COVID or COVID symptoms in general. But the other part of that needs to be balanced just as much are the safety issues. And so we've heard about, from a lot of people, their legitimate concerns, a lot stemming from previous experiences and what they've heard about from other vaccines. And I think what's really important here is to talk briefly about the difference between reactogenicity and having some issues regarding safety. Now, vaccines can, and especially the COVID vaccine, it turns out, are more reactogenic than other vaccines, but vaccines in general can react, and that's what this means. It causes your immune system to react. And that's what the vaccine is supposed to do. Some may cause people to feel it more than others, but things that vaccines are understandably leading to because of how they work, because of this is something we want to have in a positive way, stir up the immune system. You may see things like sore areas where the concentrated part of the vaccine first goes into your body at the site where it was injected. It could be sore, it could be inflamed where there's redness, and that's what erythema means here. You can have muscle aches and joint pains, be fatigued, have headaches, nausea, occasional vomiting, and even some low-grade fever. And these are things that have been variable across all vaccines, but is very commonly known to be associated with them to some degree, to every vaccine. The flu vaccine, by the way, is actually very relatively well tolerated. The vast majority of people have very minimal reactogenic symptoms, but some people do have more severe reactogenic symptoms. And I think it's not uncommon occasionally to hear people, from my standpoint, I've had my own patients, the people that I've dealt with, there's a decent percentage that will tell me, of those that are reluctant to get a flu shot in the past, that they got sick after getting the flu shot, meaning that either they got the flu, and again, all these symptoms here are consistent with what you would see in a flu, or they just flat out said, they had an allergic reaction, they felt very ill. And again, to a certain point, we expect that in these COVID vaccines and vaccines in general. But none of the COVID vaccines and none of the other vaccines that are in the market now have had a significant safety signal. This other group here on the right, where there are medically important events that are attributed to the vaccination. So it's not to say that these things on the left are not important, but they're quite temporary. And that's the other thing I forgot to underscore earlier, that even though some of these symptoms can be a bit more severe in some. They always go away within a matter of a day or two or three at the most. And there is no long lasting effect. It doesn't cause people to go into the hospital. It doesn't lead to them having a condition that they have to deal with for a long period of time. And all of this is balanced against whatever you're trying to vaccinate yourself against. Some of you may know about Shingrix, which is the vaccine that's been out for shingles. For those of you who've had chickenpox in the past. And some of you may know or have had yourself shingles, and it is horrible. And a certain percentage of people with shingles can have permanent or extremely long-lasting effects where their nerves are damaged and have severe pain. It can be disabling. It's also been associated with some rates of suicide, especially in the elderly. It can be that bad in terms of pain. So in the people that have gotten the shingles vaccine, it's known that about, I forgot the numbers, like 10, 20, 10, 15%. It's not a small number, but it's not a huge number either. But there's a decent chance that you may get some of these symptoms. And by the way, I just turned 50 and I got my first of 2 shots of the shingles vaccine, and I was out for about a day, day and a half. It gave me flu-like symptoms. I didn't feel very well. I did not like it. And like I said, I didn't do some of the things that I wanted to do because I felt that poorly. But on day 3, it was almost like magic. It went away very quickly. And I would do it again. In fact, I have to do it again. I have to get my second shot in the next few months um, for the investment that I am well protected against shingles. And that's the thing. If you get these reactogenic symptoms, it really tells you that your immune system is being primed. And uh, the vaccines that have this reactogenic symptoms with it really tend to have the best efficacy. They work the best. And the Shingrix vaccine is highly protective against having shingles. Again, I don't have the exact numbers off the top of my head, but I believe it's around 90+ %, similar to the range that we're seeing in COVID vaccines. So, you have to sort of balance this. And I think most people will say that going through a very short and limited period of time of having these symptoms, which can be in some people more severe than others, but again, very limited without long-term effects and not attributed to medically important events like being hospitalized and having any long-term issues, that is worth it in terms of protecting yourself against COVID. So part of that previous question was about talking about long-term data. And let's put this in context. You can say, fine, short term, we may get over some of these things, but what could happen to me long term? And that's a legitimate concern. I don't mean to downplay that, but let's look factually at the wealth of information we have regarding vaccine safety in general. There have literally been billions and billions of doses of vaccine that have been given throughout the history of the world. And there are very few rare adverse events associated with the vaccine that are listed here. All, as you can see in terms of the numbers, are extremely rare and all occur soon after the vaccination. So when you're dealing with a vaccine, you're dealing with short-term issues. The vast majority don't have any issues. Those that do, some can be a little bit more severe than others, but they're extremely self-limited. They go away. There can be extremely rare, very severe issues that you see here. But again, they're more in the short term. And none of these things occur years and years or decades down the road. So we don't worry about long-term issues with vaccines in general. It's really the short-term things that that we have to educate people about and that you need to be aware about and put into your calculator as to the risks and benefits behind all of this. And by the way, some of the things that are listed here are, I admit, some are a bit scary. I mean, Guillain-Barré is a very significant neurologic issue where you have a loss of the use of some of the nerves. Encephalitis is inflammation of the brain. These are nothing to laugh at for sure, but look, the numbers here are extremely rare. Again, I don't have the exact numbers, but I can guarantee you that these are, you have a greater chance of being hit by a plane part coming from the sky than some of these numbers that you see here. Certainly when we're driving the interstates of Georgia and getting into a bad accident, the risks are much higher for that. Yet we have to, and we legitimately do take that risk. And here we're talking about vaccines that are exceedingly important in terms of protecting us from many different things, not the least of which in the short term is COVID. Just to further underscore, there is no evidence of long-term issues with vaccines in general. And there are some things here that are listed, including lupus. You can see here. There's no scientific evidence for any of these things being associated long-term after having had a vaccination. So, some of the questions that have been bantied about, the mRNA vaccines are new. Shouldn't we have more safety data? And the mRNA way to make vaccines, and we'll talk more about this over time, is a relatively new technology. It has been around more for cancer, but it's the first time it's been used for an infectious disease like this. So, I think a lot of people legitimately kind of think about, well, where's the safety data? We need that. But we have had over 70,000 people, and it's hard to put this in perspective if you're not in the field, but that is a huge number of people in a vaccine trial. And it is much larger number of people in a vaccine trial than would have been in any other vaccine study for flu or for the Shingrix vaccine for shingles. So in terms of having pure numbers, we've really studied this mRNA vaccine quite well. And there hasn't been any clear safety signals. So, the level of confidence in terms of the safety of going into these vaccines for the general public, and I'll talk about lupus in a minute, it should be, the confidence should be high, and it is high. These vaccines were developed at warp speed. They can't be safe. And they have been developed at warp speed, but doing it quickly, the concern implies that there were steps that weren't done very well or done too quickly and not sufficiently. That's what you're basically worried about when you associate speed with something not being done safely. And the reason these vaccines were developed so quickly was not that any safety steps were skipped. Everything was done in these vaccine trials that were done in all previous vaccine studies. The reason why the current vaccines got approved so quickly is that there were so many resources, and the focus of the entire world were on these vaccines. And so people and the companies were going from one step to the next faster than ever before in the history of the world. And oftentimes you go from phase 1 to phase 2 to phase 3, and in between there some delays. You file it with the government. I mean, it takes some time to look at the reports. It goes the different committees within the company and to the outside. Here, everybody was all hands on deck. As soon, literally within hours of the data being finished and finalized within the computer, it was shot out to a team that looked at it. And so you get the picture. So the warp speed indicated the focus, as we all know, should be on the development of these vaccines, but it was not at the expense of any safety steps. One other concern: COVID is a new long-term is new. Long-term side effects of vaccines are not known, and as I mentioned, long-term side effects of vaccination isn't an issue. The vaccine material, when we talk about all vaccine materials, but especially the mRNA vaccines that we're talking about, the Pfizer and Moderna, again, they have to be in such cold environments because the mRNA and the other vaccine material degrades very quickly. And in fact, when it goes into the body, it only sticks around for a few days. What stays around for a long time that's most important is what that initial exposure to the vaccine material does in terms of teaching the immune system and having that immunologic memory, and that's what remains. The risk of severe outcome from getting COVID is much higher than any severe vaccine outcome. And we just talked and shared a little bit about the shingles experience. And I touched a little bit before also about the vaccine making people sick. Don't get confused about the reactogenicity, which is the very brief period of symptoms after a vaccine, which tells us that your immune system is working. And in fact, we want to see that, and it's actually good to see that. It's not pleasant oftentimes to go through that, and I'm reading some news reports from people who have been in the COVID studies, and they are getting sort of similar symptoms from what I shared and what others have with like that Shingrix vaccine. They feel like you've had a flu for a couple days, but they all recovered quite quickly from it. It goes away quickly. And know that over time, when we're looking at numbers of reaching billions of people to get vaccinated in order to control this on a worldwide level, just statistically, there are going to be some people down the road that will experience some side effects, even given the really rare numbers that I mentioned before. And I talked about how extremely rare those numbers are, of those really rare but severe side effects that can happen from other vaccines in the past. And COVID vaccine won't be any different. There's probably going to be some people that unfortunately develop very severe short-term side effects. But when you look at the numbers of people who have gotten vaccinated compared to those who get unfortunate side effects, you will see, and you will continue to be reassured, I hope, of just extremely how rare that occurs. And with every drug, with everything that we do, there's always going to be a very small percentage of people that are just outliers that get the severe issues. There was a question about mRNA vaccines and trials in children. And it is ethical in the sense that kids have been in vaccine trials before. The whole science and the ethics behind all of this have been worked out. We need to know about its safety and its efficacy in children, because that is a group ultimately that we need this information on. And since children do well, relatively well, with COVID in general, the placebo group is not as unethical. Inevitably, some children will get it, and we have pretty good experience and information to date that the kids in general that get it do relatively okay. Although there is a small group that gets this inflammatory syndrome. It's called MISC, multi-systemic inflammatory disorder, in children. It's this reactive inflammatory response, and it is very unfortunate. And some of the stories that you may hear of kids with COVID doing poorly, it's that, but the vast majority of children, thankfully, don't do as badly. Let's see. The CDC recommends 21 million healthcare workers and long-term care residents and staff should be the first group to receive the vaccine. You may have heard of that. So, and it's really up to the states, though, to determine exactly how that gets rolled out. But the guidance from the CDC is that the initial batch in the next month or two will be the 21 million healthcare workers and long-term care residents and staff. But the numbers, remember, we're estimating about 21 million in that first group. Really, the number of US healthcare workers is about 21 million in and of itself. And then you have about 3 million adults who reside in long-term healthcare facilities. So we're already over 24 million, and 21 million is assuming that that we can immunize people effectively in terms of getting the product out and so forth. So it's not going to be easy to reach these numbers. And that's where we are in terms of the process. We're really at the very start of this vaccination program, the first phase, where there are going to be supply issues, supply chain issues, where for a period of time there will be delays and there will be shortages. And even though we've identified this first group of healthcare workers and long-term care facility individuals, it's going to be at least probably a month or two before many of them get vaccinated. And who knows what other issues may occur in terms of getting this out and people getting it. Now, let's think a little bit ahead. So what's this next phase where in terms of larger numbers when they become available, and what are the groups that we will target? Basically the CDC, if you look at their vaccination distribution plan, what's after the healthcare workers and the long-term care facility people and staff is basically almost the rest of the population of the US. We're talking about essential workers that are important in terms of the infrastructure, about pharmacy, school nurses, but also people in terms of working in the front lines of different occupations and industries. We want to try to reach people at really high risk of severe disease, continuing to vaccinate people in the long-term care facilities, the older individuals, and then going into minority groups that have been hit very hard, those in correctional facilities, the homeless, we're talking college students, educational settings where teachers are in this group, people that live in congregate settings, and those that have limited access to routine vaccination services in the rural areas, disabilities, and people who are under or uninsured. I mean, this is a huge number of people right here. So it will take time before we can reach everybody. So that first group will take a few months, and the second group here will be several more months after that. So exactly when, I think people are optimistic that a lot of the US will have access to this several months from now. And for those of you that are wanting me to throw out a month, I'll leave that up to you. I just don't have the vision or the foresight or the expertise to say. And I've been reading about some projections as to when X number of people may get it or this group may get it. But the good news is that the vaccines are here and they're developed and they have wonderful results. And we have every reason to believe for the vast majority of people, it'll be safe and effective. And it's just a matter of time before they get out. And it's starting soon, and yes, it will take a long time and longer than most of us want to get access to it. But we are in a phase where we can look forward to that, and that's something to be very hopeful. So, um, what we really need is at least 60-70% of the population to have immunity to COVID in order to control the pandemic. And only vaccines will achieve this. There's been this talk about herd immunity, let people just get infected. That's just going to totally destroy the healthcare system and many people's lives and cause tons of unneeded death. The way we're going to reach this throughout the world, in this country and in our communities, is to reach sort of this level where the the penetration of the vaccine is reached. Vaccines uh, have given us the light at the end of the tunnel, but we're going to be in the tunnel for a bit longer. And we just need to maintain this. And there's, again, a lot of enthusiasm, but we need to know what the vaccine does and what it doesn't do. Vaccines, at this point, we know prevent symptomatic and severe disease. So that's great for you as an individual who's wanting to be protected and not get really sick, or die from COVID. This is the vaccine or vaccines that will help us to do that. What we don't know is if it prevents carriage and transmission of the virus in someone who gets vaccinated. So again, if you get vaccinated, um, there's a good chance, a really great chance, over 95% chance in some of these vaccines that you will be safely protected against COVID. And by the way, I forgot to mention that they only saw one out of those two vaccines, the Moderna and the Pfizer, one person who got the vaccine that had severe COVID, that meaning they got hospitalized. Only one person. So one of the trials had zero. So this will protect you, but whether the virus can stay on you or be in you, and you then transmit it to someone who has not yet been vaccinated so that you're the carrier, we don't know if that's the case. And if it is, how important is it? And how long does that issue last? So until we know more and we have a vaccine at herd immunity levels, meaning it's out in the public and people have taken it, at least about 2/3 of the people in the community are taking it, so that the transmission rate is really low. Until we learn more and we have the vaccine out there, I'm afraid to say, but all of these things that at the bottom here that have been such a part of our life uh, is going to continue to be a part of our lives. We're going to have to wear a mask even for many months into this vaccination rollout. We're going to have to continue to watch our distance and wash our hands. But these are all the initial steps that we will have to continue to take towards the ultimate goal that we see in sight that is achievable, where we have ultimate control over this virus that will remain in the community. Like I said, COVID's not going to go anywhere. And just like the flu and the cold, it's going to have its transmission in the community for the time being. I don't think anybody's predicting that it's going to go away, but we will have control of it just like we do with the flu and other viruses that we control through vaccines. Just to underscore all of this, in the next few months, again, the vaccine will not even be close to the rate of distribution that we need it to be. They project, this group here projects, over 500,000 could die from coronavirus by April 1st in total. And if we wore masks, we would save over 66,000 lives. And if we assumed that there was a rapid vaccine rollout, the impact will be just with the vaccine itself, it spares 11,000 lives. That's because initially we don't have the vaccine in enough people. So the point of this slide is in the next several months into the spring, into the summer, and maybe even to the fall, um, don't forget about the masks and the social distancing and the hand washing. This is not a matter of, oh, we're starting to vaccinate, we can just relax and walk around like we did before. We'll get closer to that point, but it's going to be still a while. Thankfully, the majority of Americans are having a positive attitude towards vaccine. When we talk about May, September, and November, all the blue lines or bars are people who would get the vaccine. And the colors down here are people who would not. And you can see that the proportion of people who say they would get the vaccine has gotten better in the past couple of months. And of the group who would not get the vaccine, about half of them possibly would get the vaccine with more information. So here's the but. And this goes to some of the questions here. Oh, okay, I mean, that's great for the people in the general public, but what about in lupus? What will the impact be of the vaccine on my immune system with lupus? And because we talked about the reactogenicity of vaccines normally, like vaccines are meant to stir up the immune system, which is good for a vaccine response. But what if the vaccine wakes up a sleeping bear and triggers a flare in someone with lupus? And that is a question that not only people living with lupus and caring for those with lupus are asking, but that's a question that the doctors are asking. And I mentioned earlier, we just don't have that information yet. There's a lot of interest, and I can tell you that there's significant groups, including the NIH, the Lupus Foundation, the LRA, a lot of other groups that are actively looking into this. And we'll have more information as we go. There's plenty of optimism, even in people with lupus, because people with lupus generally respond to vaccines actually quite well. What we just don't know is the new mRNA vaccines, is the level of immune response or the type of it. Is that going to trigger people with lupus in some way? We don't have a high suspicion of that based on the limited information that we know. But on the other hand, there's enough questions out there that it certainly needs to be asked. And again, it may not be a cross-cutting thing for everybody with lupus, but perhaps one group is at higher risk than others. But we have so many questions now, and we will continue to have questions. There will be a lot of other resources in addition to what I can try to put together. And again, don't completely rely on me, and always question me and double check sources. And I always put references and the source website and as many slides as I can. But now you even have a great resource coming out of the Lupus Foundation of America. And the link is here. It's also in the email that went out with the announcement for this town hall. And so continue to check that, the LFA site, as well as many other trusted sites. And we will learn more and more in general, but also about this vaccine and COVID in people with lupus over time. Actually, let me ask you guys one question. Please stay on, and I am going to throw a poll out. I think you should see a question. I would love to hear if you could respond for those of you who are online that can see this. The question is, at this time, do you think you will receive the COVID vaccine when it becomes available to you? Yes, possibly, but need more information. No, or have no idea, not sure. I'm going to give you 10 or 15 more seconds. Okay, here's the poll results. I think you should see it, right? We have a third of you saying that you will, a third saying possibly, but you need more information, and the remaining quarter of you are split between no and not sure. So, I think that's not unreasonable, and there's no right or wrong answer here. And part of our job is to equip you with the best information as possible so you can make the best decision for yourself. And, um, no one would fault you for that. So, we look forward to the future together. For the sake of time, I am not going to answer any questions off the chat, but we will in the future when we are able. Just a reminder that we'll continue to check out the COVID resource on the LFA Georgia website. And thank you, Terry, for all the work that you do. Please continue to send her questions by 2 p.m. every 2 weeks of that Sunday if you want me to formally address that. And until then, continue to wear your masks, be safe, and there's still a lot of good hope in the future. Have a great week, y'all.